you. I'm glad that you're here today.
Okay, so excited. This is the second time I've been invited to come present these, so I really do appreciate this. And getting the message out to the masses is what this is all about. Now, I don't have to do a lot of talk about menopause these days because I feel like everyone's talking about it right now. Like if you can't pick up your phone or talk to your friends, or I even have friends who have menopause text threads that they do group text with their friends, so everyone's chatting about it, and I couldn't be more thrilled. So I'm here to talk a little bit about kind of the whole natural phase, which may not feel normal, of menopause, and a little bit about evaluation and treatment options you might want to discuss. So to answer your question earlier, FACOG, so yes, I'm Dr. Leroy, so that means I'm a fellow of the American Congress of OBGYN, so that's the governing body for all OBGYNs, so we have to take several written exams. I even had to sit in a cold hotel room in Dallas and take an oral exam where they quiz you, gray-haired old dudes are quizzing you about what you know, and then I have to keep maintenance up for that every year, so that is my credentials from the governing body of all OBGYNs. And then secondly, MSCP stands for Menopause Society Certified Provider. And so maybe you haven't seen that one, and that one's an up-and-coming certification. Believe it or not, there is a national nonprofit organization, a collective of internal medicine physicians, urologists, primarily OBGYNs, but we are all part of what we call the Menopause Society. And that is a group who have collectively come together and set some standards to achieve certification. So meaning, again, you have to take the right test, you have to attend the conferences every year, they're usually in the fall, and so that we stay up on all of the latest and greatest scientific evidence, not what your cousin's best friend, from church told you, or what the Instagram menopause influencer told you, but the scientific evidence and the treatment options for menopause. So that's what all those letters mean. Just extra stuff I have to pay to put on my business card too. So there you go, I have to keep up with that every year. All right, so we're gonna call this, I was workshopping the title of this, and I originally called it the Hot Gal's Guide to Menopause. So that's, a play on, obviously, on how some of us feel. But mainly this is the question I get a lot of times when I have patients in my office. So I spend about half my day just seeing patients and guiding them through the menopause transition. This is a great program that TriHealth initiated January of this year, where I'm able to sit down, close on, 30 minutes, uninterrupted, not double booked, which is amazing in the physician world, and sit down and talk with patients about what symptoms they might be having, what treatments they've tried, where they think their health can be best optimized, and then kind of collaborating with them and coordinating with their internal medicine physicians, their OBGYNs, other people in their practitioner team to make sure that we're doing everything right for them. So that is what we spend a lot of time talking about, is what the heck is happening to me. And then, like I said before, when natural doesn't feel normal. It used to be that we kind of wrote off menopause as like this natural phenomenon, or sister, you'll get through it, have a glass of wine, take a Xanax in the 50s, just relax, you'll get through it eventually, no big deal, this is a natural part of life. And to that I say, well, pneumonia is a natural process too. If you get the wrong viral infection, it can lead to a bacterial pneumonia naturally. Falling out of a tree and breaking your arm is a natural consequence of that impact. Some would even argue that cancer, and not to belittle that, is also a natural process of when certain cells evolve and other cells don't keep them in check. So natural, in a lot of other areas of medicine, we tackle head on and say, no, we've got a fix for pneumonia or your broken arm or your cancer diagnosis. So that's how I approach menopause too. It may be a natural part of life. It may not feel normal. Let's see what we can do to make it feel better through this time frame. All right, so as I said, menopause is having a moment right now. It is big topics right now, and very appreciative of what TriHealth has done to kind of put in the time and effort. And this is a picture from the last conference. It was in Chicago last year, and with one of my work partners, she's also a menopause certified provider. We had a lot of fun. It's a fun conference. If you can imagine, it's about 3,000 primarily middle-aged physicians, women physicians, sitting in a conference room and having a great time and talking about all the things that are going on both in the scientific world and ancillary topics too, things about breast health and colon health, other things that apply to menopause care, not just, quote, hormones. So today we're going to talk a little bit about what causes menopause and the timeline, because you may have even heard the words perimenopause thrown out. That one's having a moment too versus menopause. So we'll talk a little bit about the differences in the continuum of that. We're going to talk a little bit about the symptoms that you're having, and I really want to normalize some of the symptoms. It's not all in your head. What you're experiencing is real. And then we're going to talk a little bit about treatment options that can really help optimize your health during this midlife time if that's what you choose to do. Okay, so let's talk about what menopause is. Does anyone know, you can't answer Dr. Cassidy, but does anyone know the definition of menopause? We'll throw it out there. And this is the textbook definition that doesn't apply to everyone. But if you open up the OBGYN textbook, or when I'm taking my tests, this is what the definition of menopause is. Now, it is 1 year or more of permanent absent periods. Now, I recognize not everyone menstruates, right? You might have an IUD or an ablation or a hysterectomy, but that's actually the textbook definition, and that's the one that we had to study and go through. So it's a year without periods. The average age in the U.S. is about 52. We know that some ethnic groups experience it earlier and later. So African Americans usually experience it about a year and a half earlier, and then Southeast Asian population often up to a year and a half, 2 years later. But anywhere between 45 to 55 is considered the normal time frame for menopause. Anything before 45, we actually call that premature menopause. So if you've stopped menstruating for a full year without any other reasons, and we think you're in menopause, that's what we call premature menopause. Over 55, we also have to evaluate and make sure that those periods you think you're having aren't something else pathologic happening in your body. So technically it marks the end of the reproductive years, and really, and we'll talk about this on the map here that I provided y'all a little bit ago, it is when we have profound changes in our hormones. And when I talk about hormones, I'm really talking about estrogen as the driving female sex hormone that we're talking about that. So perimenopause is technically the time frame and the years leading up to menopause. So perimenopause is when you may start to experience some symptoms. They may it be everything from, and we'll talk about this in a second, but everything from absent periods or irregular periods, heavier periods. You may start to get some mood changes. Sleep disturbances is a big one in this time frame. And also hot flashes, night sweats can kind of creep in during that time frame. So that is usually about 3 to 7 years, and that is the time frame leading up to menopause. Again, menopause is when you've looked at the calendar and gone, it's been a whole year since I had my period, but there's definitely a time frame before that can be disrupted, and we'll talk about that too. So I call this the menopause. So there's a lot of us out there. 46 million women enter menopause every year, so power to us. By 2030, it'll be about an eighth of the population. So more than 1 billion women will be in that menopause time frame, meaning from a year past their menstrual period all the way up until their final years. I wish I could say it was easy. I do know some unicorn folks who have come to me and been like, yeah, it was great. I fanned myself for 2 weeks, and that was it. Menopause, it was fine, no problems. I feel great. My body is functioning. Everything's going fine. So about 20% of women claim that they don't have any significant symptoms, but the majority of individuals, about 80% or more, do experience significant life-changing symptoms. And so we'll talk about what that is, but those can be everything from hot flashes and night sweats to really, really profound changes in how their body performs, how they feel about themselves. That can impact their relationships as well. So it is not uncommon to have symptoms during this time frame. All right, this is where the map comes into play. All right, Exhibit A. So that magenta line on the one side of yours represents estrogen. So there's a couple of other key players with our hormones, but estrogen's the big one, and we have estrogen receptors in our brains, in our joints, in our bones, and clearly in our reproductive tissues, all over our body, we have estrogen receptors. And in the years leading up to perimenopause and menopause, we have a fairly regular ebb and flow that our body gets used to of how estrogen comes and goes, and that results in menstrual cycles. And if you're not pregnant or breastfeeding or on a birth control, it's a fairly regular kind of sequence. In the late reproductive years, this is about 37 to 43, we'll start to see that that this line starts to have a higher, if you're a math nerd, the delta is higher. So the change from the highs to the lows goes a little bit more so. And then in our early perimenopause years, so this is about 43 to 47, we'll start to see what I call the chaos zone. So that estrogen is up one day and it's down another, and it may be stable for a little bit. You can't predict what it's doing, and your body can't predict what it's doing. And so when you are having these mood changes, sleep disruptions, something's not right, I'm raging for no reason, there's actually a reason, a physiologic reason. A main component of your overall well-being for the last 40 years of your life, 30 to 40 years of your life, has been completely disrupted. Then when we hit late perimenopause, this is about age 47 to, like I said, 52, right around that time frame when we have the menopause transition happening, we just see that estrogen tank. And this is when a lot of individuals will come in and say, all right, I thought I was feeling bad, but now I feel a little bit worse. This is really characterized by absent periods, the hot flashes and night sweats, what we call the vasomotor symptoms start to kind of play into everything. And then that will continue on for about 5 to 8 years. Some people finish with the hot flashes a little bit sooner, but we'll see that start to continue for several years. Then kind of the chaos and the deep dive off into the ditch ends. And then we have what we call late menopause, which is basically the rest of your life. So sometimes people are like, oh, yay, I'm through menopause. And I want to be like, well, technically, you're in menopause the rest of your life. It's just a different manifestation of menopause. But this is where we start to see different symptoms come up that can actually be more concerning than just maybe raging and mood changes that can actually overall affect your vitality and your well-being. About age 60, 65 on is when we start to see these things come up. So that's basically where we are in the map. Okay, so let's talk about perimenopause. It's about 3 to 5 years in length, as we talked about. And again, we talked about how it was chaotic. Sometimes I'll have people come in and they say, well, I had a period in March. It's June now. I haven't had one since. I need my hormones checked. But the problem is, back to the map there, if I check your hormones on this day, they're going to look really low and be misrepresentative of where you are. So perimenopause is a hard time to check hormones because the next day they may be really high. So we oftentimes don't do labs at all unless you've had where we can't tell what your period or your cyclic symptoms are. If you have an IUD or you've had a hysterectomy, sometimes we'll check labs, but usually we just go by what you're telling us. In this time frame, the 43 to 47 time frame, trust me, I'm an OBGYN who's been doing this for almost 20 years, 25 years, you can't get pregnant. So almost every year we have someone come in and they go, well, I didn't get my period for 4 months. I thought I was through menopause, and boom, 44, they're pregnant or something. So you can get pregnant. Your body is still trying its best to throw out some eggs from your ovaries and ovulate and keep the reproductive phase going on, even though all that chaos is happening. So we always want to make sure that during perimenopause, if you don't have reliable contraception, that we got to make sure we have that on board. However, it doesn't mean we can't treat perimenopause. You don't have to wait till you've gone through that final year of no periods and saying, yay, I'm in menopause, to treat any symptoms you might have. So this is where a lot of the dialogue has changed in the last few years, where we used to say, wait till you're 51, 52, the doctor would be like, call me then, or we'll have a conversation then. And now we're doing things to help treat women in this time frame in the perimenopausal years so they feel good, so they don't feel that chaos that's happening. All right, so again, in perimenopause, our ovaries are really doing their last little bit to get the last few eggs and the supporting hormones out, but it becomes very irregular. We stop making progesterone, which is, like I said, estrogen is kind of a driving one, but progesterone is a silent player in the background that also affects how we feel. Periods become irregular, and the uterine lining just kind of is chaotic as well. One day it fluffs up because it has hormones, and the next day it drops out. A lot of people will complain of heavy periods with like big fist-sized clots at this time frame. It's very, very common. There's other causes that we can see lead to menopause. Perimenopause is that natural kind of chaos I was talking about, but menopause can also be caused for other reasons. Permanent absent no period for a year. Surgical, so if you've had your ovaries removed for any reason, that will instantly take out the source of all the hormones in your system, and we call that surgical menopause. And that's a pretty rough process for anyone who's gone through that, because they don't get even the chaos zone. They just fall off the cliff right there from a normal kind of function usually before. Chemotherapy or radiation, so if someone's going through cancer treatments, they will often go through menopause early, or they may be induced to go into menopause if they have a cancer that is sensitive to hormones such as estrogen. And so that will be another cause of menopause. And then finally, there is a very rare condition called primary ovarian insufficiency, where we'll see that the ovaries just kind of give up before age 40. That's very rare. I've seen it twice in my career, but it does happen where individuals go through menopause in their 30s and unexpectedly. So, all right, on the other side of your paper, so we talked about the map, and that was all that is the symptoms of menopause. And I always tell people, hang this up on the fridge, or I don't know, put it wherever you want everyone to see. Check these off as you're getting them, or you can say, hey, this is not crazy. The reason why I'm having joint pain, or the reason why I'm having vaginal dryness or itchy skin, or my heartbeat feels weird, or I'm having brain fog is not because I'm losing it at age 52. It's because all of these symptoms are related to that profound drop in estrogen that our body loves. So in peri and early menopause, we'll see those heavy periods. We'll start to see some hot flashes and night sweat come in as our body loses its ability to thermoregulate because of the lack of estrogen. Mood changes is probably one of the big drivers I see people coming into. They just feel like they can't really rationalize how they're feeling towards the people they care about sometimes. Libido changes, we'll see these pop up during this time frame. I've got a slide on libido in a minute. Libido's pretty complicated and complex, and so I can't blame 100% of that on hormones. That's often a common thing. People come and be like, I just don't even care if I fold laundry or hang out with my husband. Like, they're both equally boring. So, and that, can you check my hormones? And I'm like, nah, it may not be totally, there may be some relationship and some other issues going on that. But there can be some hormone-related kind of changes to that. And then this one that no one likes to talk about is weight gain. We do experience some significant weight gain in the menopause transition, the average is like 12.5 pounds of weight gain. And an individual who's particularly savvy, like maybe someone who comes through to the sports club, that can be a big change in their body composition. So despite all the things that you've done in the past and all the things you continue to do that make you a healthy individual, you may still see some central kind of weight gain during this time frame. And then when we have later menopause, that's where we start to see painful intimacy and vaginal dryness. So as this is in those kind of maybe 60s or even beyond, and I've seen it earlier too in some individuals. The vulva and the vagina love estrogen, and so if they don't have it around for about a decade, they get pretty testy. Vulvar burning, so there's actually a syndrome where women walk around, it feels like their vulva, which is the outside of the vaginal area, feels like it's on fire, and that's not fun, obviously. And then recurrent UTIs. I think probably, if I poll most people, they know someone in their family, a sweet family member of an older age maybe, who kept getting bladder infection after bladder infection, and then older individuals don't handle those really well. They can get dementia-related kind of changes, big falls from those. And so recurrent UTIs, because that bladder, vulvar, vaginal tissue is deprived of the estrogen, can be a real problem in this time frame. And so we have to keep an eye on that and the people that we know in the later years. And then this is a big one for me, which is bone loss. When we talk about all the reasons we want to treat or deal with menopause, there's a 25% chance of dying the first year after you fall and break a hip as a woman if you're over the age of 65. And I'd be hard-pressed to find, so 25% mortality rate, I'd be hard-pressed to find other conditions. I don't think hypertension, a new diagnosis of that will give you that, diabetes, asthma. There's a couple of rare cancers that maybe have that same mortality, but not most. Tripping, falling, breaking a hip. I think everyone also knows maybe some sweet person in their life who did that, and then they lost their vitality. They ended up in a rehab center or a nursing home and never really got their life back. So bone loss is a very, very serious condition that can happen due to the menopausal changes. All right, so let's talk about some of the key symptoms that people, all right, let's see if I can get this to work. If anybody knows who this is, I'm pressed. Okay. The throwback to my 2000s. All right. So Nellie was on to something. Hot flashes are definitely something that we have to deal with sometimes. So hot flashes happen to do with some neurotransmitters in our brain that start to kind of malfunction, kind of how we perceive how warm we are in a room. It comes up here. It's not all just skin. And yeah, if you've got too many layers on, that'll impact it. But there's a receptor area of the brain that actually says it's too hot in here. I need to start sweating. I need to start fanning myself. I need to take some layers off. Even if the rest of the room isn't hot, and even if it's 60, the thermostat is set on 62, it's still, you're going to feel that. These tend to be one of the big ones that bother people because they feel embarrassed, because they feel like they're the only one in the room fanning themselves at a certain time. It feels like a very outward symptom of menopause that other people can kind of catch really quickly. And then that rolls over and gives us night sweats. And if anyone's ever had a night sweat that's significant, it's pretty profound. I call this the international sign of night sweats. You know what that means? Yeah. Sheets on and off, right? All night, like a windshield wiper. So, or you'll soak through the sheets, you'll strip down, and then all of a sudden you're freezing again. Your partner's over there like with the hoodie on, like it's so cold in here, and you've got the fan blasting and the window open in January. But yes, so the big issue with the night sweats is what it does is it disrupts our sleep greatly, and it disrupts our normal sleep rhythms and patterns, which can lead to a lot of these menopausal symptoms that we're feeling, that lack of concentration, the fatigue, the brain fog. Because if you're not getting your quality sleep, I think we all know the importance of sleep as we get older. You're not going to be able to perform the next day regardless. So. All right, weight gain is another one I get a lot of talk about, and I appreciate that people are conscientious of their fitness levels and that they want to, not everyone is maybe letting themselves, get to a point that they feel like is not comfortable for themselves. But after age 40, this is a sad statistic, if you're not working on it, you're going to lose about 1.5 to 2 pounds of muscle. So I'm talking like lean muscle mass every year. It's a body composition switch. It has to do with some of the hormonal changes and what's happening. And so for anybody who knows that, how fitness works, muscle is our big metabolic driver. When you talk about your basal metabolic rate, and muscle is working as you're sitting here in these chairs right now, when you go to bed later on, your muscle is kind of running and driving your metabolic rate. And if we lose that engine at a rate of 1.5 to 2 pounds a year, we lose some of our basic metabolic function. And so that can be where we get those sneaky 10 to 12 pounds, a lot of that central weight that people will complain of as they start to get maybe some visceral fat during that time frame. And so weight loss is weight gain and weight loss right now is a very hot topic with all of the medications and things that we have going on right now. The science, I think, is still evolving. I think we're going to have changes probably with new medications and new things out even in the next 5 years beyond what we have right now. I do recommend to women in this time frame that they engage in weightlifting. So like heavy strength training. Not like the little, I love a bar class or a Pilates class, but they have those little pink, no, we're not doing that. We're doing the hard compound movements, the big body, the squats, the deadlifts, working obviously with the trainer if you're not sure how to do that safely. And then zone 2 cardio. People go back and forth with zone 2 cardio. I still think that is a very good way to kind of help your cardiovascular health. It may not result in significant weight loss, but it will help our cardiovascular status. And that's beyond just resting heart rate, right? That's getting it up a little bit. And that can be done with a walk, a swim, that can be done with a hike. You don't have to go out and run the flying pig or train with a group. You can achieve that sort of cardio level on your own. So this is where things are getting kind of interesting now. So GLP-1s, and everyone's familiar with those. There's a couple out right now. There's a third in trial right now, and there's like 3 other ones that the big pharma companies are working on trying to do. They have been shown in some limited studies in women who are in the menopausal years, who are on a hormone replacement, who also do a GLP-1. They sustain greater and more sustainable weight loss when you combine the two. So there may be some synergy in there. So I am not certified, so that would be another set of letters after my name. I'm not certified in obesity medicine. There's a whole other group of individuals who are. And they know all of the nuances. And again, thankfully, TriHealth has a division where we have medical management, and it's not like, like where you pay. It's not like a spa kind of thing. It's where you actually sit down with a physician who's board certified in obesity medicine and weight loss tactics, and they will talk to you about that. But there is some emerging data that they're targeting menopausal women, that this may be a great tactic. And then we always want to make sure if we have some profound weight changes that we don't have a thyroid or a diabetes diagnosis. So that's where you work hand in hand with your PCP. All right, so libido. Low libido is tricky, like I said, because it's complex. So if you've been with the same partner for 25, 30 years, or maybe even longer, the dynamics of your relationship change, clearly. There is a drop of another hormone I alluded to earlier called testosterone that starts to happen around age 40. Now, unlike the estrogen where it's chaos and all over the place, testosterone just starts to slowly drift downward. And testosterone, we think about that oftentimes with like guys, it's like a weightlifting or kind of an illicit substance they do to get big and bulky. But it's actually one of the key hormones that has to help with helps with female sexuality. And so there is a place for trying out testosterone replacement therapy in individuals who are having low libido issues. Mood changes also, this is a time to explore to make sure there isn't an underlying or unmasked kind of ADHD, anxiety that may be situational, depression. There are other things that happen, and so working with your physician to make sure there isn't something else going on that we're just blaming on menopause and hormones is really important. So, all right, so late menopause. I love this slide. It's kind of blurry, I apologize for that, but truly, the vagina after late, so like age 60 or so, 60, 65, if we're not treating anything, the vagina gets shorter, it gets thinner, and it also gets narrower. So it becomes a very, very thin lining, whereas before it's robust, it has a lot of moisture secreting glands, and in the absence of estrogen, people are like, oh, it shrivels up. I'm like, yeah, it kind of does. It's an unfortunate consequence. So in addition to that, the uterus will also get small, and then ovaries tend to kind of get small as well. So we will see painful intimacy. Oftentimes patients will describe it as like a sandpaper feel when they're trying to engage in intimacy, or even like a feeling of like spasm, like because things just aren't accommodating as they were before. And so that can be also, when we're talking about libido changes, sometimes the anticipation that I really want to share this moment with my partner, but it's not going to feel good. Oh gosh, the brain kind of tells us not to feel sexy in that moment, and with good reason if you think it's going to hurt. Again, dry, itchy, burning vulvar and vaginal tissue is common during this, and so we'll even get a point where the labia, so the external labia majora will actually, and the labia minora too, will fuse together under the lack of estrogen, and so that's all part of kind of the reduction in the vitality of that area that's also represented here. And then again, the bladder loves estrogen too, and so without estrogen around, it becomes very easy to get recurrent UTIs in our older age. And that has nothing to do with wiping front to back or anything else or hygiene. It just becomes that tissue is so incredibly susceptible to bacteria. It doesn't have its natural defenses and natural ways to kind of keep itself clean. And so we'll see that in that older population as well. So again, my other big symptom that I like to talk about is bone loss. This is my great-great-grandmother, Lizina Garbarino Bertrand. She came from Italy on a boat. Incidentally, her husband fell off the back of the boat, and then she threw, I'm not kidding you, threw the life ring out, and they dragged him until he got, it's this whole big deal. There's a big bunch of like articles in the 1800s when this happened. Anyway, she saved her husband from drowning. She should be happier than this, but she also raised 9 kids, homesteading in southern Louisiana, during a pretty tough time, swamps and mosquitoes and no air conditioning. And I would say lived a pretty active, hearty life. And so this picture over here is just several days, just a couple of days before a major hurricane hit southern Louisiana. And it's the last picture she has. My family has done some great genealogy, and there's some great, it's really cool that they've chronicled all this. But unfortunately, when Hurricane Audrey hit, they're all scrambling around trying to grab their worldly possessions and flee to Texas, as one does. And so she tripped, she fell, and she's a sturdy lady, but broke her hip. So they had nothing left to do but load her in the back of like the, I don't know if it was a Model T, but in my brain I see like this rickety Model T kind of thing here. Loaded her in the back of the wagon of the truck, and God love her, she had to lay like that as they drove in a hurricane to Texas. And then unfortunately, I'd love to tell you she rallied like her husband did, but she died 2 days later. So the story about this is that bone loss is a big part of what I like to think about and be very cognizant in the later menopause years, knowing that I have a family history. I have other family members in my family who have suffered osteopenia and osteoporosis. Again, there's a pretty complicated kind of cascade how estrogen affects, but it tells our bones to take up calcium and vitamin D and all the things that keep them strong and don't leach it out into your bloodstream. And so without estrogen around, even the most hardy of us can be affected. So that's that, and the UTIs are some of the, like I said, those are the ones that I see rob some pretty neat women of their vitality in their later years if menopause is not addressed or kept in check. All right, so how do we diagnose menopause? Again, it's symptom-based. So if you come to me and you sit down and you still have a uterus and you say, hey, I haven't had a period in 13 months, I'll say, welcome to menopause. We'll shake hands. There can be labs that are done in menopause transition, but during perimenopause, as I talked about before, it's just really not reliable. So we don't want to do labs because you could be catching you on a high day or a low day. I will do labs, though, if someone has an IUD in place. So a lot of individuals still have IUDs in their early 50s and even up to their mid-50s. And if they start to experience, so an IUD usually has a little bit of hormone in it, but it won't protect you from feeling any menopause symptoms. If something's going to go south, it's going to go south on that map, regardless of the IUD. And then women who've also had a uterine or endometrial ablation, so maybe they're not getting periods, but they still have their normal hormones cascading in the background. And clearly, if somebody's had a hysterectomy, we can do some labs just to confirm that we're in menopause. So treating menopause, once we've shaked hands and said, welcome to menopause. First of all, you might be one of those unicorns, like I said, in that 20% who has no big issue, or maybe you like to tough it out and you can wait it out. You can wait it out. So about 5, like I said, at the maximum of 8 years after you go through menopause, that's when you'll maybe see some of those symptoms that were really disrupting you start to subside. So power to you if you want to tough it out. That's absolutely fine. Right now, there's been a big discussion about what we used to call hormone replacement therapy. We're now calling it menopause hormone therapy because we're not really replacing. We're not putting your ovaries back to their 20-year-old glory. We're just giving you a little bit of menopause hormone back, or hormone therapy back. And I almost think, so you maybe have heard that in the early 2000s, there was a study that came out that erroneously linked hormone therapy to breast cancer rates, and it kind of robbed a generation of women of the opportunity to even have a talk like this, because we didn't talk about it. We didn't talk about menopause. Everyone waited it out and toughed it out at that point. Or women who had been on their hormones, a lot of them had them robbed, kind of taken out of their hands by their doctors at that point. But the pendulum has swung back where we're having these conversations, and we want to give opportunities. It maybe has swung even a little too far, and that's just what happens, right, in these natural kind of life cycles, where everyone thinks they need to be on hormones. And in the right candidate, I think it's a great idea, even just for the osteoporosis prevention. But not everyone has to be on something, and so, like I said, you can try and tough it out. Believe it or not, we do have non-hormonal medications too. So there's a couple of the antidepressants done at very low levels that change the chemicals of how your body responds to being on low estrogen. That can be used. There's an exciting new medication out that is for individuals who are having profound hot flashes and maybe they can't take hormones because they have a contraindication, like a cardiac history or a cancer history. That would mean that they couldn't take hormones. And so that's available. That will knock those hot flashes out in 72 to 96 hours. It's been really helpful for our young cancer patients who've kind of been left struggling. Cognitive behavioral therapy, there was a whole day at the Menopause convention in October in Chicago where we talked about therapy and therapeutic ways to kind of talk through it, right? Validating your symptoms, talking about ways you can approach, being proactive in your workplace or talking with your friends. And so some pretty good studies have shown that just chatting about it, as we are doing these days, may help treat us to some degree. Try health. I'm not. Just promise you. I guess I'm towing the party line here. Just started a wellness behavioral group, so that's kind of a euphemism for a therapy group. It's located up at Bethesda North, and all they are doing is seeing is perimenopause and menopausal women who are having difficulty with this transition. They don't see angry teenagers. They don't put bad marriages back together. It's woman on woman, just talking with a therapist about what you're going through, and it's designated and designed to help individuals through this transition. And maybe you need someone for 3 sessions, maybe you need them for 3 years, but they're there to talk. And so I'm super excited that they've kind of taken the lead on that in pulling together a division that's just explicitly for that sort of conversation and to have it in a trusted, safe space. And then obviously lifestyle changes. If what has been working for you in the past may not be working, we got to change it. So we may need to talk about changing our exercise approach, how we approach our nutrition, and our sleep hygiene. I'm a big fan of the coolers that you can get, those little cooling blankets for your mattresses. Doing what you can to make sure you're getting that quality sleep. No screen time before you go to bed. I know that's hard, but those things can really help with some of the transitional symptoms as well. All right, but the big one that most people want to talk about and when they come to see me is hormone replacement therapy. So hormone replacement therapy, in essence, is taking that pink line on the map and providing you an estrogen level that I would probably say, again, we're not going to be back to our 20 or 30-year-old glory. We're going to be a little bit lower than that. And the dose that we use for that estrogen is significantly lower dose than what individuals have for birth control, and way less than the dose that people have when they're pregnant. So when people are like, I don't want hormones of that level, I'm like, well, it's the lowest level that we actually make and manufacture is hormone therapy for the menopausal time frame. So replacing that estrogen into your system so that your brain, your bones, your joints, your reproductive organs, everything kind of feels just at ease and past that chaos zone, but not in that ditch of no estrogen. Any individual who has a uterus also needs to be put on a progestin, and that's another kind of an interchangeable word, more or less, for a progesterone. And that's because the uterus can try to kind of grab and absorb too much of that estrogen and cause irregular bleeding. It can cause abnormal cells. And so luckily nature gave us a hormone that blocks that, and that is progesterone or progestin. The progesterone that I like to use with my patients has a wonderful side effect of bringing about really good sleep. So I have my patients take their estrogen one way, but they take their progesterone pill about an hour before bed, and it will help. It's not like an Ambien where you're going to not hear the fire alarm go off or walk in your sleep, but it's enough to just kind of get you a nice little mild sedative effect that will help you sleep. And then, like I said, it's also protecting your uterus from having any abnormal absorption. There are other forms of progesterone, but that's my favorite to use. Estrogen comes in a couple of different delivery mechanisms that are FDA approved, and that's what I'm talking about, is FDA approved kind of medications. The patch is my favorite. It has the lowest side effects. It's the easiest for me to titrate, meaning it's got about 6 or 7 different doses. I can really individualize and work with patients what works for them. It's available in a generic, and it's about the size of like a Forever stamp. It's clear, and you can sit in the hottest of hot yoga classes, jump in a lake, jump in a hot tub. It's not going anywhere. It is very adhesive. People sometimes worry about their active lifestyles that the patch is going to come off and they're going to be out of estrogen, but that's almost the opposite. It's very adherent. There's also pills that are available that are FDA approved. We can do that. And there's even estrogen creams and a mist, like a little spray that you spray it on like a perfume or something. You have to wait like 15 minutes for it to kind of be absorbed into your skin to go anywhere. And I'm always running 5 minutes behind, so that one didn't appeal to me. But it is one that if someone has like an adhesive issue or they don't do well with pills, they can use the cream or the spray. And then there is some other, there's a ring that's out now too. It's not available in generic, so I don't use it a lot because it can be expensive, but it's a little ring that looks like a hair tie, and it goes in the vagina, it sits in there. So it releases estrogen into your system via mucosal absorption down there. So technically, if you open up the FDA guidebook, it'll say there's 2 reasons Dr. Leroy or your doctor should be prescribing you estrogen or hormone therapy. And that's number 1, to prevent those vasomotor symptoms, hot flashes and night sweats and kind of the things that happen because of that. And secondly, for osteoporosis prevention. Those are the 2 things that have been studied and have been shown and verified. I can guarantee you from patients I see all the time, an incredible list, part of this list that's on the back of here is also relieved by estrogen therapy. Just because they haven't sought FDA approval doesn't mean it doesn't work. And so there are a lot of times that your doctor may prescribe a medication and use it off-label. So if I have someone coming in and saying, I'm having frozen shoulder, or I've got super dry, itchy skin, I'll usually say, let's try some estrogen. It may help you out. The FDA, if you open their book, they're going to say, well, whatever you want to do, doc, but that's not one of our prescribed indications. But I've seen it help time and time again. So just the osteoporosis prevention, if I didn't make that clear, is so keen to me that I almost think that that's a reason for a lot of individuals to be on it. So there's mixed studies about whether or not, if depending on what your family history is and what your own individual history, hormone replacement or hormone therapy may help prevent some cardiovascular issues in some studies and or cognitive decline. Some studies say the opposite. It may promote it. So when people come in and say, I don't want dementia like my mother, I'm not going to be able to look at them and say this estrogen is going to help you like that. So without the right studies right now. So for the older set who have all of those kind of bladder, vaginal, vulvar issues, we'll use topical estrogen. And the difference on that is that it's not absorbed into your system. It just kind of sits there on that tissue and makes it healthier. It gets its vitality. That's how you get your moisture and your lubrication back. It'll prevent the UTIs. And I have a lot of patients who've come to see me who just this is available in generic too, and just that little $7 tube of vaginal estrogen that they use twice a week has prevented dozens of trips to urgent cares for UTIs and a lot of well-being and kind of, at least relieved a lot of the painful intimacy symptoms they were having. So that's a really easy way if you don't want hormones, systemic hormones, topical hormones are not absorbed by the rest of your body. They work in that area. You can use topical estrogen with these other estrogen products too, so they can be layered on each other in the right person. So that's where the key is. We have to have the right person. So estrogen, like I said, not for everyone. If you've had a certain female cancer yourself, not if your mom, not if your sister, not if your grandma, if you yourself have had a certain female cancer, it's typically, there's some breast cancers that are estrogen sensitive. So if you've had one of those cancers, you will be contraindicated from taking these hormones. Back to that study in 2002, and I have a slide next up that'll talk about that. What I tell people is that even if you have a strong family history, you're not contraindicated from using strong family history for breast cancer, which is what most women are concerned about. You're not contraindicated from using estrogen. Estrogen doesn't take good cells and turn them bad. It feeds existing bad cells. So if you have an existing cancer or you've experienced that, you're not the right candidate. But if you have normal tissue, you're getting your screenings, everything's kind of checking out okay, being on estrogen won't take a good breast cell and turn it evil. Stroke, DVT, people who've had heart attacks, they are not really good candidates for this also because the estrogen will affect how the blood vessels work in these individuals, and we don't want that to happen. So also patients who are at high cardiovascular risk, so maybe they've got uncontrolled cholesterol, like uncontrolled high blood pressure, they're on 3 medications, they've got diabetes, they live a sedentary life. There's actually a calculator. I can put all of that in, and when you come to see me in the office, and I can see if you're one of those high-risk cardiovascular patients, you probably shouldn't be on estrogen either, because it can lead to situations like this. The general recommendation is that if you've gone more than 10 years from your last menstrual period, or 10 years where we presume you went into menopause, again, not everyone has that last menstrual period, the data has shown that those individuals usually don't benefit from hormone therapy. We've kind of, I hate to say we've missed the boat, but it also, the risks of developing some of these other things are a little higher, and so we try not to start it when we hit age 60. Some studies are being done in that realm right now, which may, I say 60, 62, 63, let's say you went through menopause at 52. We may push that boundary at some point, but right now we don't have the evidence to say that it's safe to start if you've gone more than 10 years since your last menstrual period. So this is just another slide just to kind of show that a lot of stuff we do causes breast cancer. So those of you who come here and you work out, you're like the lowest risk category. Good for you, because you're going to have the lowest risk of breast cancer incidence. Being on, so the average risk is 23. There's 3 to 4 extra cases for birth control pills of developing breast cancer. This is over a lifetime out of 1,000. So this is what we're talking about, not 3 or 4 cases out of 10 people. But look at this, regular alcohol, which is defined as 2 or more glasses a week, and then BMI over 30 really increases our breast cancer risk. So there's a lot of things that we do on a daily basis that increase our risk that don't quite get the same attention. All right, so there's a lot of people who have understood that menopause is a very vulnerable time frame and that we are a desperate population, and a lot of our doctors have been gatekeeping, and some of the older gray hair ones who kind of lived through the Women's Health Initiative in 2000 may not be telling you can get your hormones. You may be frustrated and you may go seek out alternate ideas. There's a lot of, I call them hormone hawkers is what they are. They're basically just a lot of med spas, compounders. We'll see, you can get your Botox or your hormones or your laser hair therapy, everything at the same place. They are using, in many cases, pellets, which kind of look like a hybrid of a Tic Tac and a grain of rice, and they're usually injected into the glute. Pellets that have hormone kind of embedded in them, they are not FDA approved. They come from compounding pharmacies, which are largely unregulated, especially in this realm. They tend to overtreat, so I'll see them, and once it's in you, we can't go dig it out. So it's different than a patch where we can adjust the dose. Once that pellet's in there, it's in there. Pellets are being used a lot for testosterone, and they really tend to overtreat in that area too. And so I just caution, everything that I'm telling you today would be covered by an insurance visit, and everything that I would, your insurance company during the visit, and everything I would prescribe for you should be covered by your insurance too, meaning you shouldn't have to pay $700 to $800 to $1,000 every 3 to 4 months to get your pellets placed. That's just not necessary. We can do FDA-approved hormone therapy in any reputable office without having to go seek out extra help. So just know that they're making money off of you, and if you want to be in that relationship, good. Just know that buyer beware, and it's not very well regulated. So this is a QR code. It will take you. I think I might be able to do it here too. Are you connected to the internet? All right, let's see if I can go there. So. This is, oh, it didn't come up on there. I may have to share it, I'm not sure. Yeah, you're probably tech savvy here. So the Menopause Society, this is the QR code. The Menopause Society has a patient portal, and that patient portal has an entire list of patient resources, and then it also has, where you can read the real science about things, easy to read kind of stuff. And then it also has a provider portal too. So where you can put in your, you can put in your zip code and ask for, a local MSCP who might be near you. So it's okay, it's all right. So that way you can find someone who's spent the extra time, has the interest, and really wants to sit down and talk to you about your menopause kind of journey and where you are and what's worked or what hasn't or what new therapies might be out there. All regular OBGYNs, we get limited training, but we do get training in our residency programs and thereafter in menopause care. It's just some doctors just don't have quite the interest, and sometimes things can be a little nuanced. And if you have a 15-minute visit with your doctor where they have to do your pap smear and talk to you about your breast health and go over, what did you wear your seatbelt and all these things like this, it's hard to have a really good in-depth conversation about menopause or perimenopause during that time frame. So, but you can sometimes schedule a separate visit. Say, I just want to talk about menopause, and sit down with your provider. And you can work on those topics. And if they don't feel comfortable or if you don't like what they're saying, ask for a referral. Every health system has a menopause certified provider within the system who can help. Or, like I said, you can take matters in your own hands and find someone in self-referral. Sad state of affairs, there's about 3,000, that's only 3,000 of us in the country who are MSCP, so there's not enough for the millions of women who are in menopause or approaching menopause. But I think, if you feel like your questions, I'm always a big fan for patient advocacy, and if you think your questions aren't being answered, you should seek it out, especially in this area of care where there has been a lot of mystique and a lot of non-discussion over the years, misinformation. Find someone who kind of knows what they're talking about, and I think it'll work to your advantage. So. And the other thing I want to kind of just throw a plug in for is talking about menopause. I think it's totally cool to talk about menopause with your kids, with your coworkers. Let's make it normal. I mean, we talk about other things. We know when a teenager storms off, we go, puberty. So you can say, reverse puberty. It's the same thing, right? Like, let's talk about it. Let's normalize it. There's big initiatives now within workplaces. Like, I know TriHealth is looking to kind of make how we can have a menopause benefits for our female team members. And so, what we can do to make their menopause years better. There's the same way that, breastfeeding used to not be even a benefit that new mothers had, right? Like, they had to sneak into the broom closet or whatever to pump. Now it's a part of their, the work culture. And menopause is going that way too. So I want us to keep talking about it. It's not some sad, scary thing or something to be ashamed of. It's just a part of, it's a part of our normal life. You may not feel normal through it, and so you can express that and say, hey, here's how I'm feeling. The chart says it's okay, and this is how I'm going to deal with that. So I always just like to make sure that we're talking about it. I have 3 daughters, God love them, and so we talk about menopause, and my 20-year-old is like, again? I know. She's like, I can't wait to move out of this house and not talk about menopause. And I'm like, yep, yeah. You'll be glad you had this conversation at some point in 30 years. So anyway, I think we may have a little time for a few questions. I can answer any questions that anyone might have. I will say I can't answer specific medical questions, and I prefer you not to bring up your specific, because of the HIPAA and the whole how we deal with that. But if you have a general question, is this safe or is this normal or whatever, I'm happy to answer anything you might have. So yes.
I actually have 2. One is I'm on the far end of it all. So I'm wondering. I'm still experiencing things, especially weight gain, hair loss, stuff like that. How do you adjust diet and exercise, which are under your control, to kind of counteract, because there's so much information about how it's different at that age. And then the second question is, does circadian rhythm fall into any of this? And
so you're saying hypothetically if someone had questions about...
Correct.
Yeah, okay. So diet and exercise, and we do have control over that. And so a lot of talk about making sure we hit our protein macros.
Right.
There's been if you want to, I don't get a kickback from this individual. There's a Dr. Stacy Sims, SIMS. She has a book called Next Level. I think it has great diet and exercise information in it. She's an exercise physiologist. It's like $14 off of Amazon. She's not making much money off of it either. But It's all about, like I said, kind of changing our mindset to exercising to be strong and to
Sure.
lifting, and not exercising as many of us did in our younger years to fit into our skinny jeans for Friday night. And so it's about changing that mindset and kind of working toward that. When it comes to diet, a lot of talk about protein and creatine and a couple of other supplements that are out there. To hit some of the protein levels people talk about, a gram of protein per ideal body weight, you got to be eating cottage cheese till like 10 o'clock at night. It's hard, right? And so there are ways I think there's some give and room in that. We do have I do have a couple of references for like nutritionists who work with the menopausal population in the Cincinnati area. I'm happy to provide that. But I think it's just kind of changing our mindset and working on to be strong versus skinny, and working out in ways that maybe embracing kind of our body composition changes. But if someone's getting a bone scan that says your bones are strong, you're doing something right. That's how I would look at it. Now there are places in town where you can go and get like a body analysis, like a DEXA fit and all of that, and they'll do a full DEXA scan and they'll look at your muscle mass and all that too, and they can give you some ideas too. I can't speak to circadian rhythm other than
cortisol,
yeah. That would be so. That's kind of blending over into the endocrinology world, which is the true hormone. Like they're the ones who are looking at the adrenals and everything happening with that. How many people here wake up at about 3 o'clock in the morning, 3 or 4 nights out of the week? Yeah. So that's typically a sign of maybe some disrupted cortisol levels, but that would be a conversation to have with your primary care doctor and to talk. Yeah.
It's just frustrating because people don't know. Like my OB says, oh well, I've just resorted to eating like a bar a day. Like that's how I deal with it. And I'm like, well, I want to be healthy, and that's not giving me nutrition, so that's out. Yeah. And my PCP she wants to help, but most people don't know MSCPs to recommend. Right. They just don't know you exist.
So on that same portal page, you can even find internal medicine physicians who are managing high blood pressure and asthma and other things, and more of like they're the ones who do your vitamin D level and your cholesterol level every year, who are MSCP certified and are into that. You just have to dig a little bit for that.
That's great.
That would empower you to do that. Yeah.
Thank you.
I wish I could handle all of that for everything, but I still got to deliver babies and do pap smears and all that other stuff too. So yeah.
That's
yes.
fair.
Yes, ma'am.
So is a bone density scan, and when would you recommend getting your first one?
So bone density scan. Has anyone here had one? Anyone want to share they had? Does anyone? So I've had one too. Yes. So bone density scan is a pretty quick lower body X-ray. It's very minimal. It's quicker than a mammogram. It's quicker than probably even getting your chest X-ray. It's pretty fast. And what it is, it's looking at the density or the level of bone development, or at least consistency, in a couple of areas. The lower thoracic spine. So that's where we'll see people when you get the hump, like the compression, that we'll see compression fractures in individuals with osteoporosis there. But also the one that I care about too is the femur. It looks at the top of the thigh bone where it meets the hip, and it looks at how much bone you have in that area. So it is giving an analysis based upon your age and other, so they've kind of looked, when you get the numbers back, it's a bunch of weird numbers on there, but basically they're comparing you to other individuals who are the same age as yourself. And is your bone level normal? Is it below it? That's the main thing we want to know if it needs to be changed. The society recommendations, this is the American College of OBGYN and MSCP, I'm rolling my eyes a little bit, says that you shouldn't have your first bone scan until you're 65. But that's anyone who has a pristine history. You don't have a great grandma Lizina. You don't have I have to say, you haven't smoked ever in your life. You haven't been on immunosuppressive medications like steroids for chronic conditions, and if you haven't had a fracture, then like an unexplained fracture, then you can go to age 65. I can find almost in all of my patients somebody who's got osteoporosis in their family, and I'm starting to offer them in the 50 to 55 range. Insurance may throw up a big red flag and say that's not what your society says, but I also think that being proactive on bone health is very important. I was on a jog and fell and broke a bunch of bones in my hand 3 years ago, and so was like, yay, now I can have a bone scan because my insurance will cover it. But that was, I mean, there's reasons you can get it. But 65 is the absolute latest, and that's if you have no risk factors. Another risk factor is average or underweight, so that's the other thing. So those of us the individuals who carry a little more heft actually have stronger bones. So there's a couple of risk factors to talk to your primary care doctor about, yeah, or your OBGYN. So yeah, I'll order those for patients too because I feel passionate obviously about that. So yes.
So if one were to have osteoporosis, and it's so serious, as you said, the risk of hip fracture, why is HRT off the table if you're in your mid-60s or older?
Yeah, so it has to do with some of the other, it has to do with cardiovascular health at that age. There can be some nuanced discussions if someone has, there's some tests called a CT calcium score, if someone's not on any high blood pressure medication, if they're, got a pretty strong health history, I will talk to them a little bit about where their risk is and what they feel comfortable with. And if they want to take a higher risk of maybe having a cardiovascular complication at the risk of taking hormone therapy to protect their hips. The studies have shown that and here's probably the big reason. The studies have shown that being on estrogen is more of a protective measure than a treatment measure. It won't reverse bone loss, but if someone has osteopenia, so you can either have normal bone osteopenia, you're starting to slide into like a soft bone, and then osteoporosis, which is the brittle or bone deficiency. So if you have osteopenia and you start it, then you may prevent moving over to the osteoporosis category.
So it might be too late.
It might be too late, right. And I struggle with that because I said earlier, not everyone needs to be or should be on hormone therapy, but in some cases, if someone's got a strong family history or some of those risk factors, and they don't have a single symptom, I'll say, hey, what do you think about protecting your bones? Do you want to put something in the bank now so that it's protected when you're 65 or 75? Yeah. So, yes, ma'am.
Is there a length of time for hormone replacement?
Good question.
When you're 60, it's over.
Yeah, great question. I totally skipped over that, so thank you for bringing that up. Okay, so it used to be we would sit down and say, you can take these hormones until you're about 55, 56. We'll give you a couple extra good years, okay? And then no data and science to back that up. Then somebody threw out the number 60. That one got kind of thrown out. And then someone said 65. Now, based on, and this all kind of came out in Chicago last year, the right candidate without any other, who has no other contraindications can go to their grave with their hormones in their hand. So I say that as long as it's keeping you healthy and you're doing well, you can stay on it. That's how I feel about it. And again, that's why you meet with someone once a year, like myself or your OBGYN, to continue to look at where your risks and your benefits are. But if it's working for you, you can keep it. Now, what we're doing, when you do that, you're kind of kicking the can down the road. So let's say all of a sudden at age 75 you decide or you can't take hormones anymore. When you come off, you're going to go through some of the hot flashes and all that again. It won't be as profound as it was in the earlier time frame, but you will be feeling some of those feelings again. Yeah. Anybody else? Yeah.
Does insurance cover the menopause visit, or is that a different thing?
Yeah, so it depends on your insurance, right? So it is a different visit. It is separate. So I'm doing them separate from the well woman visit, right? Because again, we've got some ground to cover in the well woman visit that just doesn't give. I actually set aside between 30 and 45 minutes to have this discussion. So insurance will cover it much like they will cover like a problem visit for something else. You may have to pay a copay. But yes, they'll cover it. We cover it. We code it in a way that it looks like a like the same thing you would come into a doctor for a yeast infection. You're coming in for menopause, so we kind of look at it from that same point of view. Mm-hmm. All right. Well, thanks for your attention. I hope this gave y'all some good info about what's going on and some tools to maybe talk to your physician or provider about. Yeah, we'll keep having these conversations and just go home and talk to somebody about menopause tonight. Bother somebody, yeah. Thanks again, y'all.
Thank you.